Hello. Hey, hey, hey. So that's the trick. On
Yeah, Dr. Morris is not going to approve of me using.
Okay, hello everyone. You probably already know who I am. We're going to be talking lung volume reduction surgery today. Bronchoscopic lung volume reduction. This is Hela, or Nas, as like my third year class would like to call me. And the faculty mentor for this is Dr. Peralta. Okay, so no conflict of interests to disclose. So the goals of this lecture, we're going to talk physiologic concepts behind lung volume reduction in emphysema. We're going to talk about lung volume reduction surgery, and then bronchoscopic techniques for lung volume reduction, procedural details and videos, anesthesia consideration, and our Henry Ford experience. So what is bronchoscopic lung volume reduction, or BLVR? Is it a procedure to make the lungs tiny and acute? Procedure to bronchoscopically collapse the lobe of either lung using a one-way valve, a surgery to resect the upper lobes of the lung, or a technique to fold oversized donor lungs to fit the recipient chest cavity? Who would like to answer? Dr. Kassab? So let me just, okay, correct. The answer is 2. So COPD, it's the 3rd leading cause of death globally. It's a disease that had high prevalence. You guys recognize Darth Vader breathing sounds? The prevalence in the United States go up to 10%. Like if you notice here, like Midwestern areas, Michigan, Ohio, and the southern state has really high prevalence. In terms of costs of care, in 2010, $32 billion were attributed in healthcare costs. That was projected to be $49 billion by 2020. And that ranged according to states. For example, in Alaska, it cost roughly $42 million. That was in 2010, though, and $2.5 billion in Florida. Okay. Some technical difficulties. Treatment. As you all know, medical treatment, medications, including short-act inhaled medications, smoking cessation, vaccinations, oxygen therapy, nutrition, management of acute exacerbations. And then if the patient continues to be symptomatic, you're going to do bronchoscopic lung volume reduction or lung volume reduction surgery. And this was recommended actually in the 2021 Global Initiative for Chronic Obstructive Lung Disease Guide. And then your last stop is going to be a lung transplant or palliative care hospice if your patient is there. So the new thing is that BLVR was actually recommended in the 2021 GOLD recommendations. Okay, so what is emphysema? You guys know. It's an irreversible and gradual destruction of the lung architecture with subsequent loss of elastic recoil. So your lung is going to be super compliant, like you just like inflate it with air, just like remains inflated. Emphysema is a really well recognized phenotype of COPD. It can be homogeneous, meaning that there is no regional difference in the severity between regions of the lung. Usually for the purpose of studies that were done for valves, it's like less than 15% difference between the target and ipsilateral lobes. You have heterogeneous emphysema that is predominant at a lower level, and there's like significant difference between two lobes in terms of destruction. Okay. So a problem that emphysematous patients run into is called hyperinflation. Why is that important? So it's commonly accompanied by expiratory flow limitations. You have two types of hyperinflation, either static or dynamic. Static hyperinflation means an increase in the end expiratory volume during rest whenever your patient is spontaneously exhaling due to increased lung compliance and emphysema. You lose all that elastic recoil, so you don't tend to empty your lungs as well as the normal lung. Dynamic hyperinflation is an increase in the end expiratory volume during exercise above its baseline due to worsening flow limitation. So whenever you're exercising, you're trying to exhale that air, like you have flow obstruction because of COPD, and then you can't exhale all that volume, which adds insult to injury. So why is that really important? What does it do? So basically, dynamic hyperinflation increases the load on the inspiratory muscles. It means that it increases the work and oxygen cost of breathing. It causes inspiratory muscle weakness through affecting the muscles in the diaphragm. It decreases your ability to expand the tidal volume during exercise, which leads to early mechanical limitation of ventilation. So you're trying to exercise and you're limited by your inability to expand your tidal volume, which normally increases during exercise. Your inability to expand the tidal volume, you have severe VQ abnormalities, leads to CO2 retention and oxygen desaturation during exercise. It adversely affects dynamic cardiac function, and all of the above pretty much contributes to your dyspnea and limitation of COPD. So keep that thought. Okay, so in theory, exercise performance in dyspnea should be improved by intervention that reduces any intervention that would reduce the lung volumes in rest and exercise. Okay. So we're going to talk a little bit about lung volume reduction surgery. It's interesting in the sense that it kind of like gave us a lot of ideas about lung physiology and kind of paved the way for less invasive procedures. So this surgery was described since the 1950s by Dr. Otto Brantingen. He's from University of Maryland. In his very own words, it's the resection of the most useless and functionless areas of the lung tissue. The aim of this surgery was to restore the impaired physiologic mechanism of pull on the bronchioles. It all sounds great and dandy. However, that surgery had 16% mortality at that time, and a lot of the medical community shied away from it until the 1990s. When Dr. Joel Cooper, do you guys know who Dr. Joel Cooper is? Dr. Gilani looks like he knows. So basically, he's the one who did the first lung transplant. So this doctor here, he reevaluated this procedure in the 90s after he noticed whenever during lung transplant, the fast reduction of chest volume in patients with emphysema. He tried to get more thoracic surgeons to do that procedure. And there were a lot of, like several studies in the late 1990s, early 2000s, which some of them demonstrated favorable improvements in quality of life, FEV1 and distance walk. Those were not though randomized controlled trials. It was at that time done for palliation emphysema until the National Emphysema Treatment Trial was designed and published in 2003 to evaluate the mortality, the benefit, and the patient selection for lung volume reduction surgery. So we're going to talk about very important landmark trials during this lecture. Not a lot, don't pass out, but the very important ones that kind of like, shape the way of how we treat emphysema. So basically this was, NETT was a US-based randomized controlled trial, multi-center. It enrolled 1,218 patients. And they were trying to compare bilateral wedge resection of the most emphysematous area to medical treatment. Their primary outcomes, they were looking at mortality at 2 years. They were looking at exercise capacity. They measured that by increase of the wattage of like how a patient was able to pedal on a bike. Their secondary outcomes were looking for quality of life using the St. George Respiratory Questionnaire, 6-minute walk test, and FEV1 and dyspnea as measured by the MMRC. So inclusion and exclusion criteria, those are important in the sense that kind of also pave the way for our inclusion and exclusion criteria in BLVR. So what they were looking at, total lung capacity of over 100 predicted, which would signify hyperinflation, residual volume over 150% predicted, which would signify air trapping, FEV1 less or equal to 45% and more or equal to 15%. Non-smokers for at least 4 months before their initial interview, and they would have, the patients would have completed pulmonary rehab. The exclusion criteria severely limited patients in terms of exercise. Anybody with any cardiac issues, MI within 6 months, EF less than 45%, uncontrolled pulmonary hypertension as measured of over systolic pressure over 45 millimeter of mercury on the right heart cath. And that is very important because 28% of your COPD patients have coronary artery disease. The other exclusion criteria were technical, anatomic, I would say, pleural or interstitial disease that precludes the surgery, giant bulla, over 30% of the lung, clinically significant bronchiectasis, pulmonary nodule requiring surgery, previous sternotomies or LVRS. And this is important in the sense, the use of prednisone is that like your COPD is not stable. So what are the outcomes? In terms of mortality, that was one of the primary outcomes. Pretty much it didn't show mortality benefit if you take all the patients. For high-risk patients, it was associated with higher mortality. Those high-risk patients were identified early. Those who had less than 20% of the LCO, their FEV1 was less than 20%. Those who had homogeneous emphysema. However, the investigators further split the patients into subgroups. They wanted to identify those with upper lobe predominant disease with low exercise capacity and high exercise capacity, those who didn't have upper lobe disease with low exercise capacity versus high exercise capacity. And interestingly, they found that those with upper lobe predominant disease with low exercise capacity, those are the ones who actually had a statistically significant mortality benefit at 2 years post-surgery. Those are all important information because, again, like we built like the concept of BLVR on that. So the other outcomes, pretty much the patients who got the surgery had improved outcomes in exercise capacity, quality of life, and FEV1. And again, those with predominant upper lobe disease and low exercise capacity were the ones who benefited most, and most likely because those who with these specifications where you're treating medically, they're at a bad stage and their disease progresses quite quickly to start with. So this is a question for you guys. What is not an adverse event of lung volume reduction surgery? SVTs, persistent air leaks, reintubation, pneumonia, or post-op MI? Who says one? Raise your hands. Who says two? Who says three? Who says four? Who says five? Five is correct. Remember the inclusion criteria. Your patient had to be pristine from a cardiac function, so post-operative MI was not actually noted in lung volume reduction surgery as a complication. So the adverse events, the immediate post-op complications were cardiac arrhythmias. Anytime you have problems with the lungs, you're going to end up with SVTs. Reintubation was pretty big. Pneumonias and tracheostomy. Also failure to wean from mechanical ventilation within 3 days. 30 days post-op, some had major pulmonary morbidity, 30%, meaning either a tracheostomy, failure to wean, pneumonia, reintubations, ventilation for 3 or more days. Cardiovascular morbidity was 20%. Air leaks, 90% of the patients had air leak within 30 days of the procedure. Median duration was 7 days. The surgical techniques, VATS versus sternotomy, didn't really have any effect. And those who had air leaks had more post-op complications. And length of stay was naturally increased. Okay, so costs and trends. So cost analysis of lung volume reduction surgery and trends of it. So basically, when they looked at the costs, it came up to medical costs would be $140,000 per quality adjusted life year gained at 5 years. This means pretty much that this is a costly surgery in comparison to medical care. And there were around like 3,300 surgeries done in the span of like 2000s to 2010s. This surgery has high in-hospital mortality, complications like tracheostomy, length of stay. Anybody who's older, over 65%, ILD, malnutrition were associated with higher mortality. So this kind of like started declining over the years here. Okay. So what did we learn from the NETT trial? Is that those who have heterogeneous emphysema, those with upper lobe disease, low exercise capacity, and FEV1 less than 45%, actually this is something to consider in them. However, those who have homogeneous emphysema, non-upper lobe disease, high exercise capacity, high risk in the sense of like low FEV1 and low diffusion, those probably you don't want to put them through that surgery. So now we're going to talk about bronchoscopic techniques for lung volume reduction. And another question, what do you think of the following have been tried for BLVR? Who think it's 1, 2, 3, 4, 5? Yeah, absolutely all of them. I'm going to talk about the less common ones like real quick, just like to go over them. And then we're going to focus our energy more on the endobronchial valves. So vapor, it's like heated water energy meant to induce an inflammation in the airway as a way of causing fibrosis and atelectasis and collapsing the lobe. There was one study showing improvement, however, that was observational. They had adverse events like exacerbation of COPD, pneumonia, hemoptysis, and this is not FDA approved. Lung sealants, they would inject a lung reagent inside of the lung to close up some lobes and like have atelectasis that way. There was a study that showed significant improvements in FEV1 in comparison to controls. However, it had 44 adverse events requiring hospitalization. This was eventually dropped, and it's not FDA approved for lung volume reduction. Coils. Coils are basically, coils, nitinol frame, straightened through a deployment catheter, placed through a flexible bronchoscope, and then deployed in the lung. Once you deploy them, they take their coil shape again. Actually, there was a nice study in JAMA looking at coils for bronchoscopic lung volume reduction. It showed some improvements in 6-minute walk tests generally. Had some high complications and post-procedural adverse events. But this is currently not FDA approved for bronchoscopic lung volume reduction. Now we're going to talk about valves. So valves, endobronchial valves, are one-way valves that allow the air and mucus to exit an area, but they won't let air go in. In this way, you achieve atelectasis. So we have two types of valves: Zephyr valves and spiration valves. Zephyr valves are made by pneumothorax. They have a nitinol skeleton, silicone body. They work by a duckbill valve mechanism. They're FDA approved. They come in different sizes based on your airways, 4 regular, low profile, and 5.5 regular and low profile. We also have spiration valves made by Olympus, nitinol frame, synthetic polymer cover, umbrella shaped, and they also come in different sizes, 5, 6, 5 to 9, 5, 6, 7, and 9, I do believe. So we're going to talk about the VENT trial, endobronchial valve for emphysema palliation trial. This is one of the earliest trials evaluating the Zephyr valves for bronchoscopic lung volume reduction. It's really important because it taught us a lot of lessons for subsequent trials of endobronchial valves. So it's a US-based randomized controlled trial. Oh, sorry, guys. So it looked at unilateral treatment with endobronchial valves compared with standard medical treatments alone. And the outcomes they looked at: improvement in FEV1 by 15%, improvement of 6-minute walk test by 17%, quality of life, daily O2 use, and dyspnea. So what it ended up showing, modest improvements in everything. However, it was not to a degree where it was deemed enough. The major adverse events at 90 days were acute exacerbation of COPD, hemoptysis, and pneumothorax, which were higher in intervention group in comparison to the control group. But it kind of like taught us some valuable lessons though, because it taught us that those people with high heterogeneity of their emphysema, they had significant improvements in their outcomes. And those with complete fissures, which is a surrogate for collateral ventilation, had really good outcomes as well. At that time, when people were being enrolled in VENT, we were not really checking for collateral ventilation. So this is what it taught us. Well, we're going to talk about this. We're going to talk about this. Okay. So what is collateral ventilation? Is it midway through the lecture? So what do you think it is? Who thinks it's 1? Who thinks it's 2? 3? 4? Okay. So Rebecca's right. So this is meant to jolt you awake a little bit. Okay. So what is collateral ventilation? So it's, to put it into a nice definition, is the ventilation of alveolar structures through passages or channels that bypass the normal airway. So you could have interalveolar pores, accessory bronchial alveolar communications, or bronchiolar communications, or interlobar fissures. This is where the fissure completeness comes to play. So again, collateral ventilation. In any emphysematous lung, you have new channels of communication in between alveoli. Resistance to the collateral flow is markedly decreased. So think of air taking the passage of least resistance. So if you have segmental airways that usually you have your flow go through them normally, those are collapsing during exhalation, and mucus plugging. So the resistance to normal flow of air is going to be increased, and your air is going to escape through collateral pathways. And this can prevent atelectasis in the setting of airflow obstruction. And in emphysema, generally, you're talking about complete fissures. So one way of kind of like, estimating collateral ventilation, seeing there are like actual passages in between the two lobes of a lung, is looking at a high resolution CT of the chest and actually tracing the fissures to make sure that it's complete. If you can't see it's complete, there's actually over 90%, means that probably the chance of collateral ventilation is less. Less than that, you probably have a chance that the two lobes are communicating in terms of air. This idea is really important because remember the vent trial results. So is there a way to measure collateral ventilation? There is actually. You have either CT or something we call Chartis, and we're going to talk about both. So the volumetric high resolution CT, and you get a quantitative software to actually help you with the analysis. So it's an indirect, non-invasive method. You're relying on fissure integrity. Like look here, like how you can trace the fissure here from the chest wall all the way to the opposite chest wall. As you move closer to the hilum, you really can't say if there's like, if those two lobes are communicating together or no, because you can't trace this fissure. If you've ever seen this qualitative CT software, it's either for pulmonics, for the Zephyr valves, it's called StratX. For the spiration valve select CT, it kind of gives you, it's an AI that gives you an analysis. It tells you that which lobe is more destroyed in comparison to the other and how complete your fissures are in a form of percentage. You have Chartis, which is a direct invasive method you're using through bronchoscopy. It's the balloon catheter. It's inserted through a bronchoscope to the target airway, inflated to block the flow to the target region. And this is only used with the Zephyr valves. The spiration valves don't have like a direct flow measurement yet. So there was actually one study comparing accuracy between the two, and they mentioned in the quantitative CT software analysis and evaluation of the CTs, like the accuracy was estimated at 77%, and this was estimated at 74%. So what is destruction score and fissure integrity? We're talking a lot about this. So destruction score, it's the calculated percentage of voxels and Housefield unit in a lobe that fall below a threshold value. It's too cumbersome, right? So think about it in this term of an example. If you have one lobe having 1,000 voxels and 80% of and 800 of those fall below the threshold of minus 910 Housefield units, then the destruction score is 80%. Scores over 50%, they have been used as an inclusion criteria to signify emphysema in many trials like Impact, Transform, Liberate. Improved trial actually used a destruction score of over 40%. What is the fissure integrity? You were asking about this. It's the percentage of the total area of the fissure present across the lobar boundary. It's just like you have to trace your fissure all the way. You have to see it all. So over 90% usually signifies complete fissure, less than 90% maybe incomplete fissure. There was a study looking at fissures and collateral ventilation. 95% when they were measured, the collateral ventilation was measured by Chartis. 15% had positive collateral ventilation. Those who had 80 to 95%, 50% of them had positive collateral ventilation. On the other hand, 50% didn't have collateral ventilation. So this is how you measure.
The pulmonics Chartis system provides precise pulmonary flow and pressure reading. Sets the patient's collateral ventilation. By identifying disease loads with no collateral airflow, physicians can optimize the valve placement for endoscopic lung volume reduction.
So basically what you're looking at, this is how the Chartis screen would look like. When you occlude the lobe, you see the steady decrease in the flow, and then you say, oh, they don't have collateral ventilation. However, if you occlude your lobe, but it's still inflated, then there's collateral ventilation. That is another view, like see how nicely that is decreasing and see how steady this remains positive. So there were actually like several trials since then. We're just going to do a quick summary here, and we're going to talk about the two major ones that resulted in FDA approval of the valves. So there were BLVR trials, LVO, Impact, and Transform. Those all were randomized trials that evaluated both lobes. They focused more on heterogeneous emphysema. However, Impact did look at homogeneous emphysema as well. BLVR looked at fissure completeness using high-res CT, and the others looked at the complete collateral ventilation through the Chartis system as well as the high-res CT. Basically, all of them showed improvements in FEV1, 6-minute walk tests, and quality of life, which eventually led to LIBERATE. And this is how Zephyr valves got FDA approved for bronchoscopic lung volume reduction. This trial was designed with the FDA as well. So it was US and outside the US, multi-center, enrolled 190 patients. It was looking at the effectiveness and safety of standard of care along with EBV, endobronchial valves, to standard of care alone up to 12 months, and those who had heterogeneous emphysema and no collateral ventilation. Primary outcome was improvement in FEV1 over 15%. Secondary outcome were changes in FEV1, changes in 6-minute walk test from baseline, changes in quality of care. Inclusion and exclusion criteria are also important here because this is how we qualify our patients for the valves. Our qualifications based on these trials. So inclusion, any same like lung volume reduction surgery, FEV1 over 15 and less than 45%, TLC over 100. Here, they chose residual volume over 175%. Post-rehab 6-minute walk test was 100 to 450. You had to have stable COPD. Emphysema heterogeneity was over 15% by high-res CT, and the target lobe selection was based on over 50% destruction score. Non-smoking at 4 months, and collateral ventilation was negative when measured using Chartis. Those were excluded, those with unstable COPD, those who had cardiac problems, heart failure, reduced ejection fractions, MI, uncontrolled pulmonary hypertension, core pulmonale, those who had anatomical problems like prior lung transplants, lung volume reduction, lumpectomy or lobectomy, and those who were had positive collateral ventilation. So for LIBERATE, for the primary outcome, patients who had valves implanted had significant improvement in FEV1 over 15%, and that's at 12 months. Changes in FEV1, those who had the valves had significant changes in their FEV1. 6-minute walk test also improved. Quality of life also improved at 12 months, and that is all in the valve arm. Adverse events are important here because like whenever you get patients with valves, this is what you might be running into. Pneumothorax is a big one. Exacerbation of COPD requiring hospitalization, post-obstructive pneumonia, and all of that. So for pneumothorax, it's like a very important thing after valve insertion. If you take a look here, the majority of pneumothoraces occurred within the first 3 days. So what do you think is the cause of pneumothorax post-procedure? Lung parenchymal injury with deployment catheter, general anesthesia, rapid inflation of the ipsilateral lobe. Three. Okay, one. Who thinks it's one? Nobody. Good. Who thinks it's two? No, it's not anesthesia's fault. Who thinks it's three? So it's the rapid inflation of the ipsilateral lobe. So the rationale is that you deflated a lobe, and this deflation causes rapid inflation of the other lobe that's adjacent to it, resulting in the tear. Like this lung is very diseased and very emphysematous, and you have like a lobe that's inflating rapidly, it's going to tear, you're going to end up with a pneumothorax. We're going to talk about one last trial. It's called EMPROVE. This is the trial after which the expiration valves got FDA approval. Again, it was a US and outside, multi-center, enrolled 172 patients. They're also looking at effectiveness of safety of spiration and those with heterogeneous emphysema. They used fissure integrity on qualitative high-resolution CT as a surrogate for collateral ventilation. Their primary outcome was change in FEV1. Secondary outcomes were target low volume reduction, FEV1 improvement over 15%, change in 6-minute walk test, and change in quality of life. Again, inclusion and inclusion criteria, we're not going to go over those in detail. They're similar to the LIBERATE trial with some changes. Residual volume, they accepted anything over 150%. They accepted heterogeneity over 10%, and their target lobe selection was based on 40% destruction score. It was 15 in LIBERATE. This was 15 in LIBERATE. Same exclusion criteria. Outcomes definitely improved. Those with valves did much better at 12 months in comparison to the control arm. The kind of interesting thing though is that those who were in the improved trial didn't have significant changes, statistically significant changes in their 6-minute walk test, and they postulated that is in that trial they didn't require the patients to continue rehab after valve insertion, and they said like probably this is why it did not improve as much. Adverse events, again, what you really care about are complications post-op because you're taking care of these patients, acute exacerbations of COPD, pneumothorax, air leak, and so forth. And pneumothorax, again, happened within the first 3 days. So how does the Zephyr valve work? Oh, sorry.
The Zephyr valve procedure is performed under general anesthesia or conscious sedation, where a standard bronchoscope and flexible delivery catheter are used to guide the valves into the target lobe and desired airway. Multiple valves are implanted to ensure complete occlusion of all airways, leading to the target lobe of the lung. Valves may be placed at the lobar, segmental, or subsegmental levels, dependent on the airway anatomy. Trapped air in the treated lobe escapes through the Zephyr valves until the lung volume of the treated lobe is reduced. Valves can be removed and replaced if needed. After treatment, the remaining lobes can expand more fully, and pressure on the diaphragm is relieved, improving breathing mechanics and overall lung function.
Okay. So this is how the valves are deployed. And this is the ductile mechanism, like the way it opens, allows secretions to come out. It doesn't allow air to go in. So post-procedure, what do? We pretty much know this by now. You get immediate post-procedure chest x-ray. We do it here while the patient's still in the OR. We repeat their chest x-ray when arrival to floor ICU. We do it here when the patient goes to ICU and daily when inpatient. Length of stay is like around 3 days nowadays, could be extended if the patient ends up with complications. The most important thing is the chest tube has to be placed if needed within 15 to 30 minutes tops, and you have to have 24/7 person who would be placing that. You keep the chest tube kit at bedside. For here, the chest tube kit always travels with the patient. Here we have the brick orange suitcases that travel. The patient has everything for you to place the chest tube like right wherever you're at. For us, for Henry Ford, our protocol says to give them prednisone 40 milligrams. We initiate that 2 days prior to the procedure and continue for 3 days after. That's a total of 5 days, including the procedure day. Stole this picture from Dr. Peralta. So if you take a look at the chest x-ray pre-procedure, and this is post-procedure chest x-ray, these are the Zephyr valves placed here. You see how the diaphragm is rising up nicely. Okay, Just a quick summary. This is from pulmonics. So basically, just like to summarize the whole process, you screen your patients, you see if they meet the criteria for zipper valve insertion, and then after you evaluate them, you evaluate which lobe you're going to intervene on, and then any lobe with 80% fissure completeness, you evaluate them with Chartis to see if there's any collateral ventilation, and then you place the valves if there's no collateral ventilation. Just like quick issues here, anesthesia considerations. Consider decreasing, once you implant the last valve, you have to consider decreasing the tidal volume to avoid the other lobe over distension, cancer pneumothorax. Usually here we ask our anesthesia team to drop the tidal volume to 4 mils per kg, ideal body weight. General anesthesia versus procedural sedation. Actually, the studies were done on both, so there's nothing that's recommended in comparison to the other. It all depends on whatever your institution wants to do. Some considerations, though, if you need to repeatedly intubate, the bronchoscope insertion in and out can cause trauma, so you have to keep that in mind, especially if you want to take out the bronchoscope, put the sizing catheter into the deployment catheter, put it back again, on and off. So inserting the bronchoscope through your nose multiple times, you might end up with epistaxis. There was actually one study that evaluated Chartis under procedural sedation, under Chartis measurement in procedural sedation, general anesthesia. They found like those who were under general anesthesia, like the assessment was done 5 minutes less in comparison to the other group. Here we do general anesthesia for valve insertion. Okay. Anybody watches Supernatural? No. So the road so far. So basically, the first trial was NETT. It kind of like taught us a lot. Mortality benefits in those with upper lobe disease and low exercise capacity. Improvement in exercise and quality of life. Then came VENT, that pretty much taught us about collateral ventilation, how detrimental that is for valve occlusion and incomplete lobar occlusion. The BLVR trial evaluated the fissures using CT scan. Salvio impact and transformed and evaluated collateral ventilation using Chartis. Impact was actually one of the trials on Zephyr valves that was on homogeneous emphysema. Those with homogeneous emphysema can still benefit from valves if their residual valve volume is over 200%. There's less than 20% difference in the perfusion scintigraphy evaluation between the two lungs. So even those with homogeneous emphysema still, like if they fit certain criteria, they can still benefit from the valves. LIBERATE evaluated Zephyr valves. Zephyr valves got FDA approval. They used Chartis for collateral ventilation. IMPROVE evaluated spiration valves. They got FDA approval, and they use a qualitative CT for fissure completeness. So just like quick things to talk about our own experience doing the valves. So the FDA approval for Zephyr was granted in June 2018. Our program started in January of 2019. The first procedure was in March 2019. Our total referrals to date, 482 referrals. Total procedures are 142 patients. Our inclusion criteria are pretty much similar to the IMPROVE and LIBERATE trials. We accept residual volume over 150. Emphysema score over 45, heterogeneity score over 10%. And those are exclusion criteria, pretty much similar to IMPROVE and LIBERATE. So our demographics, we had more female patients in comparison to males, more Caucasian patients. Their tobacco use was on average 51 pack years. FEV1 was 30%, residual volume the 200s, and 6-minute walk test was 250 meters. So our results, we've had improvements in BODI. We've had improvements in residual volume, 30 to 50% as a range. FEV1 improvements. 6-minute walk test was not, there was no statistically significant change. 33% of our patients had doubled their walk distance. I wonder if that is because they don't adhere to pulmonary rehab after the valves, similar thing that was found in IMPROVE. Complications, again, You're thinking pneumothorax. This is why our patients travel with a pneumothorax kit. However, in comparison to the LIBERATE, we had less pneumothorax. Acute exacerbation of COPD, 10%. And we started a protocol where we give them prednisone, which can decrease COPD exacerbations after valve insertion. And thank you all.
Under 45. We kind of worked with that with our experience here. So I brought the criteria if you guys want it, that we do here at every board.
Actually,
So if you have patients, like let us know. I've done 145 patients now at every board, the largest in Michigan, and in the United States outside of clinical trials. Pretty proud of our program. And then since we started with steroids, it's been less than 10. Right. So we really found that we're trying to publish that right now. When we get to it. But our pneumothorax rate's really low. We're like 15%. But we dropped the tidal volume, like Paula said, at 4 cc's per kilo. And then I try to get anesthesia to like extubate, let us extubate before they wake up. Because it is a lot of that like intrapleural pressure coughing, but I think, doesn't help when they're reducing at the same time. But yeah.
Yeah.
So the NETT trial
Yep.
did not show 2-year mortality.
Mhm.
I assume with the key priority subgroup analysis, they said it's a little bit came up in reduction in mortality.
Yeah.
Did any of the trials for BLVR look at mortality benefit?
I think I saw one published in 2018 that mentioned those with valve insertion. The LVR actually had some mortality benefit. There must be, at some point it's going to come out because like it's about time.
They haven't measured that.
Yeah.
The reason why I bring it up is that while this is very impressive, right? The patients, we don't have any evidence that the patients live long. From all the data that you presented, there's no evidence of hospitalization. And actually our data, which is outside of trials, and probably, like you mentioned, the longest number of enrolled patients that we did procedures on, we haven't had an improvement. Those 5.1 milliliters in FMD1, no real improvement in 6-minute walk tests. Like, what are we making better? But not measured by, so that's a questionnaire, right? As opposed to clinical outcomes, which I'm saying the quality of life is good, but hospitalization, you're not living longer.
So
The hospitalization and everything.
So it costs $200,000 to do this procedure
Total.
per patient.
Per patient.
Okay.
So
We can sell these many cancer.
sending them to lung transplant. You're giving them more time before lung transplant.
Most of them aren't transplant candidates.
We're just
The
like
goal of the
living
procedure is
symptoms.
to have quality of life and dyspnea improvement.
I'm just saying, like, I'm not trying to say that we shouldn't be doing it or anything like that, just asking other questions, like, there's a big cost associated with doing the procedure, without a lot of hard outcomes on something.
As I told you, I think only one trial that I saw that looked at mortality benefit, and those with valves had better mortality. Again, like it's not something that I've seen, like not enough, as Rebecca said. Number two, the important thing about LIBERATE trial, we didn't go into the like hardcore details like for the purpose of this lecture. However, if you take a look at the patient populations, because you're comparing complications at 45 days, definitely those who had procedure were more prone to complications. But out until 12 months, they were similar to the other population. So that was like a key piece of information. Because the trials for the Zephyr valves prior to all of that were like they would evaluate up until 3 months, 6 months, but then LIBERATE evaluated those patients up until 12 months. And like after the immediate post-op period, up to 40 days, 45 days, like going forward, patients had similar risks of like acute COPD exacerbation, so on and so forth. So having valves didn't put you at high risk for coming back and forth to the hospital in comparison to a general population. Does that answer a little bit of your questions? It's just like more information is needed because like, again, those were approved in 2018, programs started doing them at 2019. And still like you need more information in order to kind of like look at things.
Yeah, and there was a reduction of like 1.6.
Yeah.
Board score, which
Both for, there's like a component of like how you feel and like FEV1 is kind of included in it.
right, but it is a prognosticated factor for transplant, and you do have mortality. The mortality
It's a surrogate marker.
Right.
But the real predictor is actually mortality outcome.
right, but it's
And
look at the
COPD
age of the patient. They're like in their 70s. Like, mortality doesn't have quality of life. They're gonna die. It's gonna come.